Welcome, everyone. Thank you so much for joining us today for our fireside chat, Pub Health in a Persistent Pandemic World. I'm Jackie Perzudi, Head of Marketing for Prealize Health, predictive analytics company. And I'm very excited to have you join us all today for our fireside chat with Dr. Gordon Norman, who is the CMO of Prealize Health. As we get started today, Gordon, why don't you introduce yourself? Really excited to have you today. Looking forward to learning more in our dialogue. Tell us about yourself.
Thank you, Jackie, and good morning, noon, or afternoon to our audience. I'm a physician who started my career as a rural family doc in New England, but in mid-career gravitated to the business side of healthcare after getting an MBA. For the past 25 years or so, I have focused on value-based care and population health management in a variety of executive roles in the health plan, health system, healthcare vendor, and healthcare consulting sectors. What I've learned from that is that everybody thinks their job is the toughest out of all the others and that the rest of them have it easy. Clearly, from my experience, that's not the case. Recently, I've been working as a consultant to a variety of healthcare clients, and I'm delighted to be serving Prealize as their chief medical officer for the past year and a half.
Wonderful. Well, let's dive in. I am very excited about our conversation today. We'll be covering a lot of topics, including perhaps the most important one, which is the healthy skepticism that some health plan executives, including clinicians like yourself, have when it comes to the ability of population health programs or care management to actually generate financial savings, right? Even if they are producing quality improvements. Would love to hear your thoughts on if this skepticism is warranted.
Jackie, I don't really blame seasoned healthcare executives for their skepticism, as it's likely been earned through experience with multiple vendors who promised glowing results and delivered disappointing outcomes, particularly in terms of cost savings. What we know from experience is that this is simply not easy work. All interventions in healthcare that aim to improve the triple aim of improved cost, improved quality, and improved experience of care suffer from serial dilutions of effectiveness in practice, what some people call voltage drops at various steps along the value chain. And let me illustrate that. For instance, in care management, case management by health plans, only a subset of these individuals who are deemed worthy of contact will have correct phone numbers. The rest can't be reached. Most plans have a very limited number of care management staff and are constrained in their budgets, which makes it challenging for them to even test potentially better approaches to predictive modeling or anything else in their care management pathway. Assuming they're willing and able to devote some resources to try out proactive predictions, that new information flow now needs to be integrated with and compatible with their existing platform and workflows. Only a subset of care management attempts at member outreach will encounter members willing to engage them. Only a subset of those members will have conditions that are modifiable with time through telephonic care management. Only a subset of those will identify all the potential levers for risk reduction that need to be pulled to mitigate that risk. And even when the right levers are pulled, it can take months to years of sustained behavior change to really mitigate some of those risks and produce cost savings. Meanwhile, some of these levers pulled actually generate increased cost, such as more ambulatory care visits or better medication compliance, at least in the short run. Analysis of these outcomes require a sample size and a matched comparison group that may add considerable time to performing the evaluation to even see if what they're doing has achieved their goals. So this is an illustration of how friction spots or voltage drops along the chain can dilute or will dilute the actual impact of almost any promising intervention, new or old. And this serial dilution, I think, accounts in large part for the disappointing experience that we referenced earlier on. It may cause some of these executives to doubt whether care management, no matter how it's done, can reliably save cost. But in my experience, there are ways to improve the ability of care management to achieve all three AAA outcomes, including savings. And one of the most important is to have confidence the members that you're intending for intervention are very likely at high risk absent any intervention, and are likely to engage with the care manager's outreach call and have modifiable health risks that can be addressed by experienced care managers. Additionally, the most relevant recent patient information you can assemble at the point of care for that care manager's use in addressing these risks, that's going to include not only medical history, but their meds, med adherence, social determinants of health, et cetera, the greater the likelihood their future health risk can be eliminated or at least mitigated.
Yeah, thanks, Gordon. I want to talk a little bit about more about the cost of doing the right thing that you mentioned, right? Sometimes it's going to cost upfront, right? If you're getting more people into preventative care. We've talked about this before, but thinking about the triple aim very much as a journey instead of a destination. Would love to hear your thoughts on where cost savings really does fit in relation to improving quality or improving overall patient experience.
As you know, Jackie, I tend to think of this as a perpetual or at least a very long-term journey and not a destination. To be a destination, you have to know when you've arrived. I'm not sure we will ever know that we've arrived on the penultimate triple aim that can't be improved further. With new learnings and new technology and social change, I think this is a constantly evolving situation. So if it's a journey, I think the vast majority on that journey are willing to make short-term investments in better preventive care, screening, and interventions in exchange for better long-term quality of care, potential cost reduction, and experience of care.
Mm. Yeah, I'm thinking a little bit more about how health plan leaders are responding in terms of COVID response, right? And some of the lessons that we may have learned there, drawing those out from a pop health perspective. When we talk about our mission at Prealize, which is very much focused on transforming healthcare from reactive to proactive. And so when you think about the role of pop healthcare or care management generally, what kind of lessons are we seeing or shifts are we seeing as a result of COVID? And how do you think that people are, taking advantage of the opportunity to think about pop healthcare in different ways as a result of the pandemic?
We are all constantly barraged with all the awful things that the pandemic has created in our lives. And most of us, acutely feel that personally as well. But less appreciated, I think, are some of the gains that have been achieved in response to the pandemic, specifically in telehealth and virtual care, which have been necessitated by COVID-19 and under other circumstances might have taken decades or more to represent where we have come already. I think this is a permanent improvement in care delivery that will last past this pandemic. I think it's especially important for providing improved access to care for, let's say, disadvantaged populations who lack affordable coverage, who may not have primary care doctors, who may lack easy transportation for office visits. And I expect home-based care and care in non-traditional settings will continue to increase given the ability of technology to replicate many of the benefits of a traditional hospital setting without many of the attendant liabilities of inpatient care. And obviously, we have to continue vigorous efforts to catch up with the deferred care due to the pandemic. We know that many of these screening visits have been deferred. Some, regrettably, appear to be permanently deferred. Hopefully, most of them can be made up with routine oversight of chronic conditions as well as overdue preventive screening catch-up. And while pursuing evidence-based pandemic prevention and treatment at the same time, which is critically important. I just want to put out a short acknowledgement that we have to acknowledge the pandemic has caused some blurring of the lines between social behavior and health behaviors, which normally are very separate spheres of influence. Preserving our individual and collective health now is much more of a public event than it was pre-pandemic. And when one's individual behavior influences the health of others in their community as well as their own, then preserving the collective welfare of the community has to be balanced with that person's individual autonomy. Currently, we also know that political overtones associated with these issues make it difficult to have open, constructive dialogue for many people, but we simply have to get beyond this challenge to make significant and sustainable progress in pandemic suppression.
Yeah, that's really interesting, Gordon. And I'd love to tap into that a little bit more. This idea of kind of who's responsible for health, right? When you think about kind of overall patient health, is it me? Is it my health plan? Is it my doctor? Who's responsible for that? And kind of what are some of the trade-offs that you see in being able to balance that?
That's an evolving answer over time. I mean, historically, individuals were pretty much in charge of their own healthcare, and nobody else was likely going to intervene in that process unless it was immediate family members. Then we had social institutions, religious institutions step in the role of being healers. A century ago, developed a much more scientific approach to the medical profession, and they are charged with some portion of that duty. But at the end of the day, I think it's we individuals who need to own substantially we need to be armed with what we know needs to be done and make sure that we're getting it done with the help of well-trained professionals who hopefully encourage a shared decision-making type of environment so that it's not them dictating to us or us simply dictating what we think is best to ourselves. It's a combination of informed consent and motivation on our own part.
Yeah, no, thanks, Gordon, for that. Thinking about the consolidation that we're seeing in the market, health plans acquiring more provider groups setting out their own health plans, thinking about, the Kaiser gold standard, if you will, of an integrated plan where the patient is very much involved, but everyone has that aligned incentive. Can you talk a little bit about some of the market shifts are there and maybe the role of value-based care in helping to kind of balance that out towards the greater outcome?
Yeah, along with the great resignation has been shifting in the marketplace from employer-based care to sometimes more public plans and an increase in the uninsured as well. So populations who are at risk and needing help may look different to the various sponsors of those programs, like health plan and provider groups, than they did some time ago. Some are struggling with social determinants that make it difficult for them to do what they know they need to do, what they want to be able to do, but have to struggle to be able to do it. And so I think we need to broaden our scope of inquiry about who needs what are the sort of 360-degree factors that are dictating their future health risks. Our crystal ball has gotten better for the next 12 months, in some cases, next 18 months, rarely 24. We don't have a good long-range crystal ball until genetics reveals that for many of us. And I think we're on that pathway, but fairly early. But I think with this broader scope and with advanced predictive tools, we can be much more precise about not only who to target, but what to target when we outreach to try and improve their situation.
Yeah, thanks for touching on that, Gordon. And I think, an important consideration is what tools do pop health leaders have available to them to be able to see both the short and the long-term range when it comes to be able to prioritize that outreach. You mentioned, in your first answer, appreciating a level of skepticism because most often pop health leaders are strapped for resources, right? And they're advocating for that every day. So I'd love to hear your thoughts generally on, predictive analytics as part of the solution to be able to solve that critical issue. And then also some of the short and long-term advantages of doing that.
Unfortunately, a lot of the current predictive work that's being done by those in a position to do something about those risks are based on rules-based, algorithm-based, or grouper-based models that have been in the marketplace, perhaps with some evolution over time, but relatively incremental, for 15 to 20 years. And also, unfortunately, when assessed by independent third parties like the Society of Actuaries, many of them have only modest predictive value, and they often cluster in very similar range of accuracy so that there's not a tremendous difference in moving from one to another. Only in recent years have AI and machine learning in particular allowed quantum improvement over those prior models, and we're delighted to be providing that service to our clients and partners. It's amazing what we are able to do with just a number of years of administrative claims data from a health plan in extracting between 100,000 and 200,000 features on which machine learning can work its miracle to determine who's really at future risk in the next 12 months. When we add in more clinical information, such as lab work, genetic data on a permission basis, I think is coming. Patient self-reported data will be coming. And more recently, social determinants of health. I think our power to predict groups of risk that have been completely outside our view will come into focus more, and we will have much improved ability to target the right people in a economic fashion.
Gordon, you shared a little bit about this in your intro, but you've been doing this for a long time. And I know that you yourself had some experiences earlier in your career where you were looking, on the provider side for tools that could help you with this. And so we'd love to hear kind of what that experience was like for you. And, how would that have been different if you had some of the predictive analytics available today?
Yes, you're well aware that in one of my early business roles, I was in charge of a health plan informatics group and quality improvement activities at that health plan in 8 states. And I struggled to find a model that performed as well as I thought we needed it to justify investing care management resources in the expensive proposition of reaching out. And frankly, I was skeptical that we would get consistent results. And in point of fact, that's what we found. There were inconsistent results. The people who benefited greatly. And to me, that offset some of those where there were not the predictive cost savings. But another thing I discovered at that point in my career is a paper that gave me pause. I still recall my reaction after reading it was sort of shock and amazement. And this is a paper produced by previously obscure researchers named Bayless and Boren, and they documented that it takes an average of 17 years for new healthcare innovations to be adopted by a majority of physicians. More than half of that process is consumed by the incremental spread and adoption of innovation after it's already been out in the published research for a period of time. It's very sobering that that was the case 20 years ago, but even more shocking is that that study has been replicated within the last 5 years, and it still turns out to be 17 years. And that is sort of stunning for those of us who live in an era of AI and machine learning and predictive modeling, to think that it may require 17 years for this too to become widely adopted. I don't think that's the case. I think health plans and health systems who want to enhance their ability to target and mitigate future risks more accurately and reliably than they have in the past, this can be accomplished today, and that this so-called care management 2.0, informed by modern predictive modeling techniques, can and should be pursued by health plans and providers, armed with the knowledge about which patients are most at risk for which problems, how best to engage them, how to initiate and sustain health behavior change to mitigate those risks. Whether they always save money or not, I think that's rewarding and appropriate activity for providers and health plans. And I personally am very hopeful it's not going to take anything close to 17 years for this to become widely practiced.
Yeah, let's talk about that. That is a fascinating stat. And certainly, as a nation, we cannot wait 17 years, right, for health innovation, right? We are in desperate need of new tools to do better by ourselves and by the members that we serve. And so kind of thinking about that, we talk about healthcare generally as being slow when it comes to innovation. But we've challenged that a little bit in the pandemic, right? We saw in the start of the pandemic about 10 years of innovation and adoption of health plans when it comes to telehealth that they thought that they could never do, that they shrank into 10 weeks. And so thinking about that hope that you have, what is it, about, for example, predictive analytics that would need to show this tremendous value for health plans to more quickly adopt it?
I think that many plans have gotten more sophisticated over time, from very simplistic sort of pre-post comparison or average comparisons to more advanced methodology in terms of measuring what's been happening. They're using industry standard approaches to matched, observational cohort studies, difference in difference approaches using propensity score matching to make sure that the comparison group and the treatment group, as much as possible, appear identical at the start of the observations. And then the change over the course of observation is compared from those two groups. That can be a very powerful tool. It's not as good as randomized controlled trials for eliminating bias, but let's face it, in healthcare, to do a truly randomized controlled trial where you know that half the group is going to receive a placebo, quality intervention is often regarded as unethical and inappropriate. So for that reason, I think the tools for measuring experience are pretty good. And we've used some of those same tools to show what's been achieved by some of our clients using predictive models while they simultaneously were using some of their legacy models to manage a portion of the population. And that gives us the ability to make a contemporaneous comparison with those two approaches, the same staff doing what they've always done on the same platform, the same patient population. And the only thing that differs is the use of our predictions versus the legacy model. So I think that can be very valuable. But let's talk about the pace of change in a broader context. In the immediate post-ACA era, a decade or so ago, many people thought we were going to make great strides in the triple aim of reduce cost, improve quality and experience of care, and that we'd be way beyond where we are right now, a decade later. I'm personally not disappointed by the progress. I mean, that's 10 years compared to Bayless and Bourne 17. Arguably, they would have said we'd gotten nowhere in 10 years, but we have made notable quality improvement. Many plans have lifted their HEDIS and STAR scores. They've improved their member satisfaction with improved CAHPS and HOS scores. Some, not all, have seen some noteworthy cost savings along the way for these activities. But rather than a disappointment, the fact that we've overcome the fragmentation, complexity, competing interest, and other inhibitors to change in our industry is pretty remarkable. We've got a long way to go, but I think we should not be ashamed of the progress that's been made. What we do need to acknowledge is that we need to move faster from fee-for-service type of reimbursement for healthcare to value-based, where you're not paid just for activities or widgets, as they say, but paid for results in the triple aim, results in efficiency, results in quality, and results in satisfaction. And I think as long as we are progressing down the road of more advanced and broader value-based reimbursement, both the health plans and providers, we will continue to make further progress beyond where we are.
Yeah, Gordon, let's talk a little bit more about kind of the incentive alignment. We do, in this shift from fee for service, which is by nature very reactive, right? We're waiting for a patient to come, and then maybe we're going to promote some other expensive forms of testing or whatever it is, right? How are we going to see, our leaders, both on the provider side and on the health plan side, a change in their need to adopt better tools for enacting value-based care, right? And keeping that level of accountability. What are your thoughts?
Well, it's interesting because we earlier referenced a group that's, somewhere between pessimistic and cynical about the value of doing it because they've not seen the results they expected or were promised by vendors. And yet they somehow often lack the interest or willingness to make, appropriate changes as technology advances to try and improve their performance. So I think what is lacking in some cases is a fundamental commitment to ongoing continuous quality improvement of their processes, of how they do, of how they are informed about care management, of the training of the care managers, of the data usable by their care managers, now including health disparities and social determinants. And each one of those incremental improvements, I think, can add up to a lot of more risk mitigation, patient satisfaction, quality of care outcomes, and ultimately long-term cost savings as well. So those who have lost the faith in case management as it's been practiced in the last 20 years, 10 years, 5 years, I think should be mindful that it doesn't have to continue to be done that same way. Using newer tools, in particular, AI-assisted ML-based predictive modeling can be a big head start to a more refined, more accurate risk population for expending their efforts, and then doing it with the information about who's likely to be engaged, who's got conditions that can be managed, what are the ones most likely to drive that risk, and what are the social determinants that could inhibit action on their part in doing that mitigation.
Yeah, I definitely want to double click on SDOH. You've mentioned that a number of times in our conversation today. And, it's interesting, obviously, as healthcare leaders, we've been talking about social determinants of health for 20 years, right?
Yes.
And we've been talking about it, right? And I feel like the pandemic has exposed inequities in our healthcare system that have always been there, but now has shown such a light on it with the disparities that we're seeing in race, socioeconomic status of individuals who are, contracting COVID, dying of COVID, or even being able to get vaccines from COVID. So would love to hear your perspective generally on the role of social determinants of health in pop healthcare. We're seeing a little bit of a shift, but a little bit too slow. And this idea of no one wants to hear about a problem that they can't solve, right? And so, starting to see this shift at health plans from, social determinants being the foundation's problem to being part and parcel of the care that they offer their members. So would love to hear your thoughts generally on, one, is that shift in mindset happening fast enough? And two, for leaders who do believe that it's a problem that they can help solve, where do they even go to get that data, right? That in itself is such a mess.
Whether it's happening fast enough, I won't address. The fact that it's happening at all, I am thankful to see. I think as much as we all sort of commonly can fundamentally understand that inequities and disparities create perverse and pervasive impact on our population, for many of us, it's not a palpable problem on a day-to-day basis. We can see it in statistics, we see it in reports, we see it in editorials, and we see it in, incidents or anecdotes along the way. But I am delighted to see that some serious people are making serious efforts to understand these phenomena much, much better at a level where we can begin to know how to do something about it. Two examples from our own company's board of directors. Dr. Mark Smith on our board is working with David Brailer at Health Evolution to create a framework for understanding disparities and improving equity using all the known healthcare measures like HEDIS, stars, gaps in care, and cross-cut by areas of known disparity, race, gender, socioeconomics. I think that's very important work, and there's probably nobody better than Mark Smith to be working on that. Board member John Doerr of Kleiner Perkins has recently published a book on climate change, but interestingly, he focuses as much on climate inequity as he does climate change. And, it wasn't long ago where most people threw up their hands. Why talk about climate change if we can't do anything about it? But we now have evolved to a point where there are many things we can do about it. Whether we have the will to do them is another question. And that involves political structures, government, public, private interest, et cetera, and that's an ongoing negotiation. But I think we've recognized it's a broad problem. It doesn't hit all of us equally. Socially disadvantaged, and disparate communities are probably affected more. And we need to be mindful of that in developing interventions and solutions to the problem that are not applied, broadly in the same vanilla way across the entire population.
Yeah, no, I mean, your point about climate change and starting to see really a sea change in how, as a nation, how as a community, we're reacting differently to problems outside of our individual sphere, and thinking more about kind of that collective responsibility that you talked about before. Another area where I'm kind of seeing that overlap start to develop is around the role of population health when it comes to our behavioral and mental health, right? This week, we saw that the US Surgeon General actually issued a warning about the youth mental health crisis, which we've known for some time, right? And we've seen the effects of the pandemic in exacerbating that. In fact, we are actually, publishing our 2022 State of Health report in January, and we call that out as escalated risk for next year, seeing an 8% jump in youth utilization of behavioral health services. In that report, I know you read that warning by the Surgeon General. Vivek Murthy actually calls out the role of predictive analytics and technology companies to be able to work side by side with healthcare leaders to be able to earlier and better identify youth and adolescents who are at need of behavioral health. Would love to hear your thoughts generally about how that partnership is going to play out and what role we can all play as healthcare leaders in helping to mitigate that crisis.
I think we all appreciate personally and broadly how disruptive the pandemic has been on our ordinary lifestyles and routines. What I think many have failed to appreciate is the degree to which that disruption for youth and children has possibly been more damaging than we realize just based on surface, symptoms or outgoing signs of distress. But in many cases, the lack of social contact, the lack of being outside, the more sedentary lifestyle, the increased eating of comfort food, understandable, but not necessarily healthy, has had a deleterious effect on mental health, adult and arguably even greater in our youth and children. And with gun violence rising, both youth and adult, with car accidents and reckless driving behavior being more evident among teenagers and other adults, and in suicides rising. I think hospitalizations for suicide attempts for teen girls has risen by 50% in the past year. I mean, 50% should be a striking number that demands immediate action. I'm happy to say that our company has been focused on behavioral health risk for some period of time, but I think focusing on that is going to be very important for all healthcare entities, certainly health plans and providers, because in many cases, it will be below the surface. It will not be what patients come to the office to talk about. And they may even be resistant when it's raised by a provider to do some talking about it. Hopefully, most of them are well aware of what resources to go to, but a great thing we can do in care management and providers is inform them about the risk, and if they're having suicidal ideation or making plans or have exposure to firearms, how they can make their environment more safe, how they can respond and talk to appropriate individuals who can help talk through the issues for them and get them into whatever therapy they might need.
Yeah, I would also add to that, there is, ability to mitigate the crisis through better outreach and training, but also the ability to be able to identify those individuals who are at risk even before they get diagnosed, right?
Yep.
And approaching those conversations in such a way that helps reduce the stigma, right? Talking about sleep as a driver of mental health, right? Or diet and exercise, as you suggest, instead of just jumping in to what feels still to many members that we work with, a big and scary thing, right? Breaking it down into its unique core components. And most importantly, identifying those who are going to be most likely to rise in that risk so that we can get in front of that sooner.
Jackie, you raise a great point about the stigma, because the stigma is, not only a real and problematic social issue, but it's also inhibited individuals from seeking care that could enter into the claims database that we might have to work on for predictive modeling. And so they may go to non-traditional providers of care and counseling that don't generate administrative claims. They may pay out of pocket to see a mental health specialist in order simply to avoid that getting on their medical record. We have oftentimes in my own practice, I had patients who would not allow their physical health providers to speak or communicate with their behavioral or mental health providers because they wanted to keep that divided information in their lives and in their, in their health journeys. Unfortunately, we can ill afford that, in our current complex environment. And happily, we have enough information already in what we are provided to be able to surface cases that have not had an outright mental health diagnosis made, but appear to be at rising risk for a behavioral health issue that could prompt either self-harm or, emergency room visit for attempted self-harm or even a hospitalization. And we can surface that and allow our clients to explore that, hopefully in plenty of time to decrease the risk.
Yeah. You just kind of provoked this very vivid visualization of the silos in which we operate in healthcare, right? I see my therapist for my mental health. I see my PCP for my annual wellness visit. I see my, specialist over here for any other needs. And there, in most cases at the member level, isn't that interdialogue between those providers, even though it turns out I am one person and all of those things are very connected. What role do you see of, either care management or pop health leaders at the plan to be able to kind of lead us towards more whole person care? And then what role does predictive analytics play in supporting that journey as well?
Regardless of health client, let's just say our client or partner motivation and our own, we're never going to get to all the sources of insight and truth in our health journey because, in years past, the things you told your bartender might be more relevant than the things you told your doctor. These days, it's probably your Pilates teacher or yoga coach. But you're sharing insights about your mental and behavioral health all the time to friends, hopefully, family, hopefully, providers of care, hopefully, but in some cases with none of the above. And so it can be hard to get at. I think our expanding the scope of data that we can get our arms around, lessening the stigma associated with being able to talk about behavioral health issues and risks and problems, coupled with motivation by leaders in healthcare, health plans and providers in particular, to want to surface these, normalize them, and deal with them like any other health risk is the sort of three-part, combination needed to make significant progress.
Yeah, you have an interesting point, and I wonder how much we're seeing this shift of willingness for us as individuals to actually provide that level of information or level of detail so that we can get better care. Think about, was just in Oregon for the weekend visiting my in-laws, and they have an Amazon Alexa in every single room that we are giving our information to constantly for the convenience of being able to play music on demand or order from Instacart, in the moment when we're in the kitchen making dinner. And so, we see this as well. Of course, we have digital banking that is now personalized. Amazon knows what I'm going to need to order after I, place my order for all of the dog treats that are in my bag, right? Like, what is the trade-off and where do you see that evolution going of, as individuals, a willingness to provide more data, both to our healthcare providers and the plan to improve our overall experience and convenience in receiving care?
It's a moving target or a moving line, if you will. And I think there are very clear generational differences in our willingness to do that kind of sharing. On the one hand, a lot of us who've, moderate to high mileage users of life have an active fear of an Orwellian Big Brother future who's all knowing that everything we say within the earshot of Alexa and Siri is going to be aggregated in a database and used for non-benign purposes. However, our younger brethren and sistren are obviously eager to share all manner of facets of their life in social media to an extent that their parents often find horrifying. But who knows? Maybe that pays off in being able to identify their future health risk earlier and more effectively, and the boomers will be proven wrong. At any rate, there's a balancing point. I think it takes a careful delineation of pros and cons, as much safeguards against the cons as possible, and constant encouragement, possibly with tangible incentives, to facilitate the sharing of the most important data points that we know of for predicting future risk.
No, that's great. Thanks, Gordon. I have, a couple more questions, and I see a few questions in the chat as well that I definitely want to make sure we get to. But I'm thinking about your role as a clinician and as a provider, and we've been hearing so much about provider shortages in this country, as well as provider burnout, right, which was pervasive before the pandemic, and especially for doctors and nurses who've been on the front line for the last 18 to 24 months. That this is a major issue. And so, curious your thoughts. Again, we talked a little bit about what you would have done if you had better tools when you were practicing. How do you think that predictive analytics could potentially help alleviate at least some of the pressure points that we're seeing with provider burnout or shortage?
What PCPs in general, and I think many physicians who try and practice either solo or in small groups, both of which I tried, learn very quickly, is that the task that one has to do fill far more than a typical workday in a work week. They're almost unending unless you have substantial augmentation of your reach and ability. And so when I was in a solo practice, that caused me at the time to bring on a nurse practitioner for some aspects of care, a physician's assistant for some a counselor, and a dietitian, who were actually better at doing the things they did than I was in doing those. But the patient knew that I would be getting all the information. I would continue to be their provider. I would coordinate all that care. So it wasn't going into silos. It was all staying under the same umbrella, if you will. And I think what we're seeing now is, the so-called medical home model with team-based care do much the same thing, where providers don't do every single task that they conceivably could do. They delegate much of that to other people practicing at the so-called top of their license to do work very competently, arguably better than the provider would have. And the provider concentrates time and focus on those problems, both therapeutic and diagnostic, that only they are likely to solve within the practice. And then they maintain a coordination and social relationship with all their patients, so they know that this isn't piecemeal effort. It's a coordinated, collaborative effort. And so I still think that model has tremendous promise for the future.
Yeah, it's like healthcare as a team sport, right?
Exactly.
Yeah. Awesome. So a question from the audience in the chat, and then I have one more question for us to wrap up. Let's see. I'm not a skeptic about the impact of predictive analytics on pop healthcare, but my leadership team is. How can I help them understand the value? We talked a little bit about that, but would love any additional thoughts you have.
I'm suggesting the best thing that they can do is to get valid studies that show what predictive modeling done, in current fashion with ML and AI is able to do in other organizations like theirs, and to have enough interest about that to be wanting to talk to either the principals at that client or us, or arguably both, to see how that was done. To what extent could that experience and those outcomes be replicated in their organization? That's my first suggestion.
Wonderful. All right, I know we're at the top of our time, but my last question for you, Gordon, is looking into your crystal ball, right? We're wrapping up another very challenging year for us as individuals and as a healthcare system. Looking into your predictions for the future in 2022 and beyond, what is the future for pop healthcare, and how do you see a shift in predictive modeling to be able to better meet the needs faced by our health plan clients?
I'm going to predict that we will see an increasing migration from 1990s model predictive logic to more AI and ML based. Now, having said that, we all know there are people who claim to be using AI, but when you lift up the hood, there doesn't appear to be a lot of AI going on underneath. And so the audience is going to have to develop more critical thinking about how to validate AI as truly producing a better result that they could not achieve with some of those older models. Secondly, I've already referenced the fact that I think we're going to have broader inputs of data to make these tools even more predictive than they are today. Cancer care has been markedly affected already by genetic data and a complete revision of our understanding about cancer genetics being a very personal, N of one kind of thing. This so-called precision care, person-based care and genetically based care, I think will also begin to bleed over into our predictive modeling with time, with appropriate precautions about Orwellian implications. But I think that patient self-reported social determinants will all add horsepower to our predictive modeling and raise our positive predictive value above where they are now, which is often 60, 70% into the 80s and 90s, and not too long.
Wonderful. Gordon, it was such a pleasure to talk with you today. I'd like to thank both you and, of course, all of our audience and those of you that submitted questions. We wish you certainly happy and healthy holidays to your family. And we look forward to having you back for our first event in January. You'll be receiving some communication about our State of Health report and subsequent event series, which Gordon will also be joining us for. So thanks again, Gordon.
Thank you, Jackie, and thank you all for attending.
All right, take care.